Everyone out a stapled packet, so if everyone could grab one of these as it goes around. I'll send it this way. And then in this bag are some pebbles. So if everyone can grab like 2 or 3, especially the clinicians, walk away with at least 2 pebbles. Okay. And so today's chat is on ACT, or acceptance and commitment therapy, not ACT, but ACT, and that's part of the therapy itself. And so if anyone's interested, there's also some books that can be helpful. This green one of the authors is one of the founders of ACT, so it might be a little bit more grounded in the origins of it. And then my favorite is actually ACT Made Simple by Russ Harris, and it breaks it down a lot simpler than this one does. So you can take a look at those as well. Okay, let's see if this works. Great. So if you guys remember this is July, back in the June meeting, we did a needs assessment, and there was a wide range of skill level among this group with ACT. So we had a couple of clinicians rating themselves as pretty highly skilled, probably more expert than me. And then about a third of us are about moderately leveled with ACT, and then at least half of us have 0 to no experience with ACT. So keeping that widespread skew towards novices in mind, that's how we kind of develop what we're going to be talking about in today's content with these main objectives. First, I want everyone to develop some sort of baseline understanding of what ACT is and its guiding principles, then increase our understanding of how you can incorporate ACT into a BHIP short-term model, and give everyone a little bit of exposure and hopefully some experience with doing ACT. And particularly within these 2 elements of ACT, one talking about values and goals, and the other component known as cognitive diffusion. These are specific skills I tend to use most in BHIP, and then also as a team we identified them as specific training needs. Okay, so to learn ACT, you have to do ACT, and so we're going to be doing a lot of experiential activities, so exercises I'll be guiding you through today more so than probably didactic instruction. And so I invite you to use these experiences with yourself, so maybe not thinking about your patients but your own personal struggles. And be open to acknowledging what those struggles are, at least privately, and where your edges are. And you can go as close to your edge as you're comfortable with today. And you might do some sort of cautionary statement like this with your own patients, knowing we want to stretch you, but not send you to the point where you can't kind of come back into the room. Okay. So, ACT was developed in the 1980s, so relatively recently, by Steve Hayes, and it's rooted in relational frame theory. It's a very language-based theory, but we're not going to go anywhere near it. It's kind of like, to do ACT, you don't need to understand the theory behind it, just like you can drive your car without knowing how the engine works. Same idea. And so a simple way of describing ACT is it's a very mindfulness-based behavioral therapy. Now, within that, you help bring your patients towards 2 core actions. One would be values-guided actions, or STEPS behaviors, and the other mindful actions. And I think where people get a little intimidated or weirded out by ACT is this other way of knowing it, which is a very experiential, humanistic CBT. So it gets a little heady and all that, but I think it's fun once you get into it. So I mentioned Russ Harris breaks down ACT very simply. He was in that ACT Made Simple book. He describes the aim of ACT as to help us create a rich, full, and meaningful life while accepting the pain that life inevitably brings. Okay, so that might sound a little familiar to some of our other therapies, and we'll get into that. And hopefully if you get nothing else from ACT, what I want you to get is that it's very experiential and it's an active therapy. It's not talk therapy. Okay, so how is ACT different from our more traditional psychotherapies? And you guys would all agree that most Western psychotherapies are very focused on the assumption you have to reduce symptoms in order to lead a better life, right? That's our goal. Get rid of your depression symptoms, get rid of your anxiety. ACT is very radical in that it takes a very opposite approach to that. It's all about focusing on taking a mindful, values-guided action in order to have a high-quality life. And that's possible no matter how many symptoms you have. You can have a productive, happy, meaningful life as long as you approach your experiences mindfully and you just approach it with awareness and willingness. Okay. And so Within ACT, they theorize that there are two core processes that lead towards psychological suffering. One being cognitive fusion, which is where you're all tangled up in your thoughts and you're wrapped up in them. That's all your whole world is. And then also experiential avoidance. Get rid of those unwanted things, painful memories, bad thoughts. I don't want them, get them out of here. And so with those kind of two things is where a lot of human suffering gets tripped up in. Okay. So with ACT, what you want to do is create this experience of having anxiety or depression or whatever it is and move in the direction of what's important to you. It's not only possible, but it also leads you to that more meaningful, rich life. Okay. So for me, ACT is, you break it down, it's not about symptom reduction. That tends to be a bonus. I wouldn't ever articulate to a patient, we're not going to make your depression go away. We're not going to make your symptoms go down, unless your patient brings it up first. Then you can use that as a bit of a buy-in. Like, I have this great therapy for you. We know that pain is part of life, so let's go this way. And it tends to get a little bit better buy-in. But if your patients aren't coming out with you, don't tell them your goal is not symptom reduction. That'll get them out your door. Okay. What you will end up doing through all of your different ACT modules is helping change their relationship with their symptoms so they're not getting in their way. They're not holding them back. Okay. It might sound a little bit familiar to what we're already doing, and that is, the more you practice ACT, the more benefit you get from it. The more benefit you get, the more you want to practice it. It's this filling loop. You are going to help build your patients' awareness of their unhelpful thinking styles, which sounds a lot like CBT. And there's this joint idea of blank and blank, brings to mind DBT, and building distress tolerance. So there's a lot of overlap, and it's not going to sound as foreign as you might think at the outset. Okay. So Raquel, if you could come on up. All right, so Raquel's going to help me model a metaphor. So ACT is very metaphor-based. Okay, so you can have a seat here. And so because ACT is very experiential, it can be kind of existential, it's hard to talk about it. And so it's very based on metaphors and experiences. So there's a clipboard metaphor you can use. I tend to use it more when I'm talking with other clinicians about ACT because it gets a little lengthy when you're doing with patients. But Raquel will help me show you what to do, and then if you were actually doing it with a patient, you'd want to stop at every point and debrief with them, see what they get out of it, pull in their own experiences for it. Okay. So let me just grab a chair real quick. Okay, thank you, Raquel. So the clipboard or any heavy book or object you might have in your office symbolizes pain. Any kind of pain your client has. Painful thoughts, memories, images, sensations, maybe there's a medical illness, any kind of struggle. It's all in this clipboard. Okay. So Raquel, I'd like you to take the clipboard and grip it really tightly so I can't pull it away from you. Okay. Now pull it up in front of your face, almost touching your nose. Okay. So this right here symbolizes cognitive fusion. So that's a patient who's all tangled up in their thoughts and that's all their world is. When you're debriefing with them, you ask them how easy it is to engage in a conversation with you. If you started dancing or doing weird faces, could they see you? What's their experiences of the room around them? If you ask them to do something like cook or hold a baby, could they do it? And so that's a very concrete way of showing cognitive fusion. Okay, can I have the clipboard back? Thank you. Now I want you to take the clipboard and push against it like this with both hands and push really hard.
I have a rolly chair.
Come back in. Pretend to push really hard. Okay. So you have your patient push against you and you push back and you kind of talk with them like, what are the things you're doing to make your pain go away? Maybe you've gone to therapy before. Maybe you are smoking weed or yelling at your mom, missing curfew, skipping class, all those things that they do that you've heard about in maybe your intake or as you're getting along with them. And so this exercise symbolizes experiential avoidance. All those things you're trying to do to get rid of your pain. And then in their debriefing conversation, you might ask them, like, what's it like doing this? How long could you keep it up? What can't you do while we're doing this? So the conversation's possible, it's a little bit more difficult. You still can't do things like cook or hop on the subway or whatever that is. Okay, take it back again. And can I put this in your lap?
Yeah.
So you guys can't see it because of the table, but I'm gonna put this in Raquel's lap. Okay, So now we're asking, what's it like having a conversation with me with the clipboard in your lap?
Do you want answers?
No, that's fine. It's a lot easier, you're more engaged, you can see the environment, you can do things with your hands. We didn't get rid of the clipboard, it's still in your life and your experience, but now you're freeing up your energy and your focus to be able to do other things. So by putting the clipboard in the lap, you're mirroring or modeling cognitive diffusion, so separating out the tanglement from the thoughts and putting it down here. You're not doing anything to get rid of it as much as you might want to, but it's still there, but you can now live your life. You can cook if you wanted to, you can feed your baby, whatever it is. Okay. Make sense?
Yes.
Questions? Thank you. All right. Yes. Go.
Do you use those terms with the patients too, or do you just sort of do you use cognitive? I see a question.
Okay. So yeah, cognitive fusion is like this.
I mean, do you use those terms with the patients, or do you just kind of?
I think you could use your judgment with it. It's not necessary for the patient to know the terms as long as they get the concept. But if you have a very intellectual patient who really wants to know that kind of thing, it might help them to know what to call it. Like, oh, I'm getting caught up in my thoughts right now. I'm fusing with my thoughts. But I think you could also break it down into layman's terms and be just as successful.
I had a teen yesterday, he calls that in his bag. He was like, I'm so in my bag. So that's the psychological term.
I like that better than. All right. So this picture diagrams all of the 6 core processes of ACT. We're not going to go anywhere near most of them today, but it just kind of puts everything in a nutshell in one clear picture. And this depicts wanting to move your clients towards psychological flexibility. Okay. So towards putting the clipboard in their lap, getting out of their bag. Okay. So essentially, accept your thoughts and feelings, be present, choose a value direction, and take action. So in your packets that I gave you, the stapled one, the first sheet is front and back. In the front it says sample, and the back of it is a blank copy. This goes through the 6 core processes of ACT. If you're interested, feel free to read through the worksheet on your own and try to identify some case examples from your own work life that you've noticed your patients are getting struggles with here. And on the front, thanks to a suggestion by Dana, I wrote out some examples from my own cases. I haven't used ACT with all of these families, but when I was reading through the questions, it reminded me, like, oh, this reminds me of this mom or this kid. Okay. All right. So one of our next big questions is, when is ACT appropriate, right? So in the literature base, there is empirical support for a surprisingly large range of problems, anywhere from anxiety, depression, OCD, schizophrenia, borderline personality disorder, stress, chronic pain, drug abuse, chronic diseases, adjustment to cancer, weight control, diabetes management. You name it, it could probably be treated with ACT. But when I think about the core aims of ACT and what's unique about it, the other holes in our other therapies start popping up a little bit. So for me, I think about, has this kid been in treatment before? Have those other treatments failed? Maybe they've done years and years of CBT and they're still struggling. Maybe their problem is chronic or it can't be eliminated. So you want to promote how are they going to be able to still live their life while this uncontrollable situation is going on. Maybe their cognitions are accurate and they're not going to change, but they're unhelpful, they're holding them back. Maybe your patient is stuck in the past, or they're stuck overly in the future, or whatever's going on right now they can't control, but they still need to figure out, how do I do what I need to do? Okay. ACT is not appropriate for certain situations though. Anytime there's a language weakness, you might want to steer away from very ACT-focused treatment. So most kids on the autism spectrum probably are not appropriate for ACT. Traumatic brain injuries, there usually is a language impairment associated with that, and really young kids, because they're very stuck in the concrete world and ACT is very up here. Okay. So this table highlights some examples of when I've used ACT before. The top 3 were where I incorporated ACT into other treatment approaches, and the bottom 2 were mainly an ACT-focused approach. So names have been changed, but I just wanted to give you a flavor of when you might be able to use ACT. So Sierra was a 12-year-old with a really bad relationship with her mom. ideal, perfect student at school, but when she got home, it was a totally different situation. And so before diving into any sort of family work with them, I spent some time with Sierra working on identifying what are her values and goals, what's important to her, and then helping her figure out what's the disconnect between what's important to her and what she's currently doing. And so when she kind of grasped that, it helped her engage more with her mom in the other parts of our therapy. Dee is a 16-year-old who was suspended a lot and was on probation for fighting at school. So again, with him, targeted clarifying what's important to him, what are his values, his goals, and then working with him on contacting the present moment, which is more of that mindfulness, right? What's going on with me right now and what's going on in the environment. Okay. Kayla was an 18-year-old with a pretty complex trauma history. My bigger goal was getting her ready for long-term, but in the meantime, I wanted to kind of give her help her stabilize a little bit more. She went through a wide range of self-destructive behaviors. And so with her, we worked a little bit on cognitive diffusion, or creating some space between what's going on in her mind and her daily actions, clarifying a little bit what her values were. She had a hard time with that, so we just left it a little bit more vague. Like, I know I don't want to do what's going on right now. I want to be better than my mom was. And with her, she really sunk into this idea, or this metaphor for ACT called passengers on the bus. And that's her go-to. Like, when Dana's patient knows he's in the bag, my patient noticed, like, oh, I need to be back in control of my bus. And so passengers on the bus has the patient being the driver of a bus. All the passengers are rowdy passengers, so they try to derail you. They try to make the bus driver go in a different direction. And each passenger is a different painful experience or thought. And so when she's noticing that she's getting away from what's important to her, what she's trying to do with her life now, she notices her passengers are back up front. She needs to kick them to the back of the bus. And that works for getting her back in line. And then Sam was a 15-year-old who had recently broken up with his girlfriend, and he was really stuck in that. So with him, we did a full course of ACT, 6 sessions, working on decreasing his idea of the control agenda, like I had to be able to fix everything, and increasing his willingness to tolerate the pains in life. And then Julius was a fun 20-year-old with illness anxiety. He really took to the idea of mindfulness, and we did that in like 2 or 3 sessions, and he was good to go. Has anyone else used ACT? I heard Dana's mentioned it, Katie. What kinds of cases have you used it with? Whoever.
I've used it with a lot of my teens who come in where it's usually parent-child conflict, and the teens, like, I'm fine, but they're engaging in some pretty destructive behaviors. And so I usually start off with some motivational interviewing and then switch over to the values and goals, helping them to tolerate their current life situation, but what actions can they take to bring them closer to their goal. And I don't know if you're going to talk about it, but I usually use like a compass as their metaphor.
Mm-hmm. Yep. Okay.
So I'm actually going to say the opposite, which is that I have no background at all in ACT. I guess I've used some of these things in the context of other things that I know.
Yeah.
But I'm wondering, are you going to talk a little bit more about how to do some of those things that you're talking about, involving like being able to decrease the control agenda, being able to kind of accept the pain or the suffering that may be part of their experience?
A little bit about that. I think it's with ACT having so many different pieces, I had to focus in on a couple of different ones. But that might be a good question for us to come back to at the end after we've talked a little bit more about these other things and seeing like, okay, now that you know a little bit more about this, how does that get to what you're asking about? You follow? Sue?
The last one you said you just did some mindfulness in 4 sessions.
Mm-hmm.
What's mindful ACT? Like, what's the difference in mindfulness and ACT versus other mindfulness, and what do you do in 4 sessions? You don't have to go through the whole thing.
Yeah, I think my way, I came into mindfulness through ACT, so I don't really know how it might be different from the other ones. I think it's probably really similar.
So you just did like the basic mindfulness exercises?
Yeah, and then had him do things like daily routine mindfulness, where you go out and you're on the bus or the train, let me be aware of my experience now while I'm brushing my teeth, taking a shower. And then he then started adapting it to other things. When he's noticing he's getting caught up in his anxiety, he would bring himself back into maybe doing a grounding exercise or something to bring him back to the present moment.
It sounds like I'm going to make a metaphor. It sounds like a buffet. Like ACT is a buffet of all the good stuff from all the other good things.
I kind of think so.
Yeah, I find the difference a little bit in the mindfulness to be
the focus on acknowledging and creating space for discomfort. And when I found mindfulness separate from the act, it doesn't have that component as much.
Being mindful. You're not
Right, it's just
hanging
being
out with
aware, but with a mindfulness like leaves on the stream,
Yep.
it's more so like notice how you might feel in the chair, pressure to move your leg.
Noticing
Is there
your
enough
thoughts.
space?
Yeah.
Is there enough space within you to tolerate that discomfort? Can you be aware of that and still sit in the chair? So I feel like that.
Yeah, I think that sounds nice.
I think, Paul, this is just to your comment, the best way to understand ACT is to do it for yourself.
Yeah.
And I think that that's more so than anything because we are so heady, you'll start talking about it. But really, like, doing this exercise, doing those exercises on your own, they're like 5 minutes.
Yeah.
Hugely powerful.
So we're actually,
for you
we're going to
first
do some of that together.
before you're
So yeah, so while I'm leading you through some of these exercises, again, do it for yourself, like Kate is saying, and I think it'll make this all make more sense, because right now it's very heady, metaphorical, and it's not as real or as concrete as filling out some charts for CBT or writing filling out that diagram. Okay. So just briefly, as part of the induction to therapy, particularly if you want to be more ACT-based, you want to really normalize human suffering with your patients, so make them aware that they're not the only one with pain. And so you might cite some statistics like, I'm by the mall in Bartow, so I'll say, next time you go to the mall, count every 1, 2, 3, 4, 5th person. If you ask them the right questions, you could diagnose them with a mental disorder. Or in your high school or something like that. You might disclose a little bit about yourself. You know, you don't have to go into the details with them, but say like, half the time I feel like I'm a really bad therapist and I'm always wondering like, am I doing enough? So just they know like everyone's got something that they're dealing with. And I think it helps kind of them realize like, all right, everyone else is going about their life anyway. My teacher's got some issues on her own, but she's still going ahead and teaching the class. She's still showing up. Okay. And with that, you talk about something called the control agenda, and when is control helpful in your life and when is it not helpful. So helpful for things that are outside the skin. So it's raining, you put up your umbrella, it protects you from the rain. That's an outside the skin problem. For inside the skin problems, our brain is less good at solving those issues, right? So if I asked you to think about Justin Bieber, you can do it pretty easily, right? Especially I bring up a picture of him, we're good to go. We have that image of Justin Bieber. Now stop thinking about him. Stop thinking about his songs, stop hearing his voice singing Despacito, stop thinking about all that stuff. And the patients start like experiencing that little like discomfort, like I don't really like him, but I kind of do, and you keep talking about him, and now I can't stop thinking about him.
I'm singing the song.
Exactly. Exactly. All right. So mindfulness, right? It's a huge piece of ACT. My social worker actually gave me this image. And so cognitive diffusion, like Dana was saying, is a piece of mindfulness in ACT, but because we talked about in a lot of our other therapies, Dana mentioned it a little bit in her hypnosis training, Martha, Blair, and Annie talked about it when they did DBT. We're not gonna spend much time at all on mindfulness as a whole, but I did include in the resources I emailed you and on the iDrive a lot of scripts that I tend to use, so feel free to pull from them. And I think here's where you could adapt this for some of our language impaired patients, right? You could adapt mindfulness to be very concrete for a little guy. Maybe you bring in some candies or flowers or help them listen in on what's going on in the clinic. So you make it really specific and keep it brief, and you'll be able to get it a little bit more. For people who work with Healthy Steps a lot and you're mostly working with your parents of infants and toddlers, maybe teach them a little bit of mindfulness to help with that self-care that you're always trying to pull them towards. Okay. Any other questions so far?
So I think somebody mentioned doing MI in the beginning, I think Katie. So how would you differentiate like your typical MI intervention versus doing kind of like the values clarification or like looking at goals?
I think with ACT you get very specific about it, and you do specific exercises to pull for what are your values in this area? What are your values in this area? What are you successful at? What are you not successful at? And how do we achieve a goal right now? So I think it's a lot more structured. and you pull it into kind of daily life a little bit more versus MI, which is you're focusing really on what's the problem at hand right now. I think there's a lot of overlap. So any skills you have from building values within MI or pulling up discrepancies, you can definitely pull into when you try to dabble into ACT. Okay. All right, so perfect segue to talking about values and goals. So this is one of the key training areas our team as a whole had tried to come up with or identified as wanting more of. Okay, so when I introduce this to teenagers, I try to do it more as a guided discussion where I get them to tell me the answers. I'll ask, so if anyone's familiar with Socratic discussion ideas, you're asking your patients these bigger ideas and gradually getting them closer to what you want them to say. Okay, and most of the time they get there. You might have to help a little bit, but they have some concept of it already. You're just helping them articulate it. And so what I want kids or patients to come away with is understanding what's the difference between a value and a goal. So values are what's important to you, what matters most. And if you think, Katie mentioned the compass, so I'll show you the life compass in the next page, but you think of your values as your compass, right? You're walking through the woods and this is helping you figure out which direction you want to head towards. Okay. Meanwhile, goals are very concrete, specific, desired actions. So you put them on a to-do list, you can check them off when they're done. Values never really end. They might shift or grow or change, but you can't cross them off your list as done. I'm the perfect ideal human. Okay. And so if your values are like your compass, your goals are like pit stops along the way. Okay. And the more you help them understand this, you can build in this idea of a workable choice, where are your actions helping you towards your goals, towards what's important to you, or are they taking you away from it? So is skipping class or yelling at your teacher really helping you go to college? Probably not. Okay. So we're gonna again now go to the handout, and I want everyone to turn to the page that looks like this. It says 80th birthday party. Okay. So with your patients, the goal for this exercise is you pick a milestone birthday. So with teenagers, I'll usually use the 21st birthday party, but for us, we're using 80th birthday party to cover the range.
To cover the range.
Okay, I don't think we have any 20-year-olds, so 21st birthday party, not that great. But in your resources, I sent you this worksheet where it says 21st birthday party. Okay, so again, I want everyone now to get comfortable in your chairs and allow yourselves to close your eyes. Okay. So I want you to imagine you're at your 80th birthday party and you have your eyes closed and you're thinking about making a wish before blowing out the candles. Your friends and family are there as you're sitting in front of your cake. And as you're thinking of the wish you want to make, you start looking back on your life as it is right now, here today, in this room. Then in your mind, finish the following sentences. I spent too much time worrying about. I spent too little time doing things such as. If I could go back in time, what I would do differently is. Really let yourself touch those things you most long for. How would you want your life to have been if you weren't held back by your struggle? Once you have the ends of those sentences in your mind, you can open your eyes. Okay. So with a teenager, I might have them actually fill out the worksheet, but for us, just how did that go? How did it feel doing that?
I really liked it. and it was fun to think about, and I think it does help, like, you put into words like your values and like prioritize things.
Okay.
The one thing that came up for me that I was thinking about is, do you find that sometimes people get stuck on the if I could go back in time, where they pick like one event or one thing that's already happened, and then it becomes less helpful for moving forward?
I think that could happen, and that's important information for you as their therapist, and you can use that then to kind of, like, all right, I need to work with them a little bit more in that particular area. I think what ends up happening most of the time is they start realizing that there's kind of a difference between what they wish they were doing and what they're actually doing.
Yeah.
That's what happens most of the time when you do this type of thing.
I'm wondering if could that be corrected just by clarifying that you could go back in time to this moment now, versus anywhere back in time.
Yeah. Yeah, I think you could, because what I wouldn't just do the exercise, have them fill it out, and you're done with it. Then you want to bring it into a discussion with them. So I think that's a good way of then kind of addressing that, Paul. Just like re-clarifying the instructions. How are things right now? If you could do something different from what you're doing right now.
So I know sometimes, like, you'll have someone that's really stuck on some past choices that they made and the guilt with that.
Mm-hmm.
And so I think you're right. It's easily, if you're talking about it.
Yeah. All these things, like, you do them with them before you talk about it, and then you debrief with them afterwards. And I think through that is when they start getting the meaning from what you're doing here. Okay. So on here, you see kind of two blurry images of worksheets. These were sent out to you. They're on the iDrive. Maybe this one? I don't know. This one with the compass breaks down values into different domains. And I give it out to patients to help spark their thinking about, like, what do you mean value in my education or value in family life? And so the questions, I think, help spark their thinking a little bit more. And then I use this worksheet for them to record it on. And you could do it on a worksheet, you could do it verbally, whatever feels right for your patient. And I'll often do it with them, at least one domain together, to model for them what to do. And then if I feel like they can handle it, or I want to see if they'll do it, I'll send them home to do the rest of it on their own. So first you have them go through and fill out a couple words in each box, what's important to them. Then you go back in and have them rate 0 to 10. How important is that value to you right now? Then go back again through all of them and rate 0 to 10. How well are you living that right now? And so how effectively are you living that value today? And so usually by the end of it, you then sit with them and look at the whole picture. And from there, you work with them and discuss with them what's really important to you and what are you actually neglecting right now. And Katie, I think it was Katie had sent me an example online. Someone else had mentioned it in our needs assessment. You could also do this as a values Q sort. So whatever feels more natural or you're comfortable with, you achieve the same goal. And from there, you could also identify or help teach them what a SMART goal is. So specific, measurable, achievable, realistic, time-bound, relevant, and then help them come up with one and have them do it between sessions, depending on what your goals are with them. Okay. Any other questions on values and goals before we move ahead to our next section? Yep, go for it.
I'm thinking through as I'm saying it now.
Yeah, absolutely.
But I'm wondering whether do you ever have a situation where a teenager will be like, my value is my creative life, and then based on this exercise, they realize the importance of dropping out of high school to pursue that, that hip hop career that they really regret not having done when they're 21 and looking back. I'm wondering if is that possible within, obviously this is just one exercise within a larger context.
Right.
And so there's also going to be talk of perhaps, what those choices would perhaps, what the outcomes could be. But how does that fit into this, how would you sort of roll with that in this context?
I think you could do it where you break that down a little bit more for them, what does that mean, and kind of help them carry through the consequences or the steps of that. And then you could also shift it towards focusing on goals that are more realistic or achievable for these 6 visits, right? And then put it in the context of why they're coming to see you. And you know what, at the end of the day, it's technically their life, even if it's at odds with what their family or you as a doctoral level psychologist might think is important.
I feel like you could have fun with that too.
Yeah.
Kanye worked at Gap. Like they need to have a backup plan. Drake was an actor.
Yeah, and the therapist is not the authority.
Yeah.
That we're a sharer of suffering. We all experience suffering. I'm not a master more than you. So we give them that autonomy.
I also use the Q-sort method where they come up with their top 5 values. And if I've had the experience where someone's like, I want to drop out of school, like, this is what I want. But then one of their other values was connection. And when they wanted to drop out, they're like, I'm not going to see my friends. I'm not going to be able to do those things. So you were able to use, or I was able to use, help them see what other values they had to figure out what would be the best path for them in this moment to achieve their goals later. So that was helpful.
Great points. All right, time for another exercise. So I want everyone to take one of your pebbles. Does everyone have pebbles? I'll give you 3 pebbles. Okay, take one of your pebbles and put it in your shoe. And I'm gonna do it also. Put it in your shoe. That's kind of a cop-out.
It's in my
It's in your shoe with your foot in your shoe.
My foot is in my
Fully in your shoe, please. Okay, that's all right. I'm going to respect your edges.
Oh, you know what? No, it's in the arch area.
Okay. All right. So, okay, everyone, I invite you to again sit with either your eyes closed or fix your eyes on a downward spot. Sit comfortably in your chairs. Starting at the tips of your toes, notice what your feet feel like as they rest in this space. Notice them resting on the floor. Observe the positions and sensations in your legs, and notice where they touch your chair. Continue up your body and notice where your back and shoulders rest as you sit in this space. Trace your noticing all the way to the top of your head. Be aware of your body as it rests. Now, with your eyes still closed or fixed on a spot, shift to noticing what your mind does. Stay on the lookout for any thoughts or images, as if you were a wildlife photographer waiting for an exotic animal to emerge from the jungle. If no thoughts or images appear, just keep watching. Sooner or later, they'll show themselves. Guaranteed. Notice where those thoughts or images seem to be located. Are they in front of you, behind you, above you, to one side or the other, maybe within you? There's no need to do anything with the thoughts, just notice them come and go. Maybe they linger for a little bit. Okay, and then when you're ready, you can open your eyes and come back to the room. Okay. And then I want everyone to either sit in pairs or trios and talk about what that was like. Maybe share, if you're comfortable, one thing that you noticed your mind was getting up to. And then how could you adapt this for school-age kids?